Good morning, good evening to all speakers, session chairs, and commentators. Of course, Prof. Kato as well. And today is our 24th ACNN Webinar. We are honored to have Professor Rajiv Jha, Professor of Neurosurgery, Senior Consultant Neurosurgery and Head of the Department. And he is also the Director, Department of Neurosurgery, National Academy of Medical Sciences, Kathmandu, Nepal. And currently he is the President of Nepalese Society of Neurosurgeon. Today his topic will be, so today Prof. Rajiv Jha is going to talk on a neurosurgeon's expectation from a neuro nurse. And our second speaker will be Prof. Danilov, Gleb, and he's a neurosurgeon, clinical researcher, biostatistician, statistical programmer, data scientist, software developer of Badenko's Neurosurgery Center, Moscow, Russia. He's going to talk to us on impact of AI in neuronursing. Prof, our session chair will be Prof. Gopal Raman Sharma. He's a professor and head department of neuroscience, Nepal, City Hospital, Dalipur, Nepal, and President Cerebrovascular Chapter of Nepalese Neurosurgeon, Society of Neurosurgeon. He is also the past General Secretary of South Asian Association of Neurosurgical Societies and Fellow of International College of Surgeons. And our second chair will be Prof. Ahmad Ammar. He's the chairman of the Department of Neurosurgery, Faculty of Medicine, Delta University for Science and Technology, Gamasat, Egypt. Our commentators today will be Prof. Nasser. He is the professor of neurosurgery, Cairo University, Egypt, first vice president of the World Federation of Neurosurgical Societies. Second commentator will be Prof. Igua. He's the Deputy Director, Department of Neurosurgery, Tsinghua University, affiliated Beijing, and Tsinghua Chanko Hospital, Beijing. And our third commentator will be Miss Apita Monta, and she is the Chief of Nursing Institute of Neurosciences, Calcutta, India. So may I call upon Professor Yoko Kato to give us a few words before we start the webinar.
Okay, so thank you very much for everyone. So that today is a great lecture that we are very much expecting. Maybe both. The one is from the Society President of the Nepal, and another one is AI expert. So very much looking forward to your lectures. Thank you very much.
Thank you, Prof. Kato. May I call upon Prof. Gopal Raman Sharma to introduce our first speaker, Prof. Rajiv Jha.
Yeah, thank you so much, Professor Kato and the whole organizing team for giving me this such a wonderful, the time to speak, chair the session of this webinar. The Professor Rajiv Jha is one of the leading young, dynamic, versatile neurosurgeons of Nepal. And he's the president of Nepalese Society of Neurosurgeons. And currently, he is the head of the department and professor of Department of Neurosurgery, Peer Hospital, NAMS. And he holds many degrees like MBBS, EMBS, MCH in neurosurgery, IFANS in Neurosurgery, and FRCS from Edinburgh. And he has published many many papers in the index journal, and he has published more than 70. You see the case series, and he has also published you see the more than 30 videos, intraoperative videos in YouTube, and he's very dynamic, and he's one of my best colleagues. And I would welcome Dr. Rajiv to deliver your speech. Thank you so much.
Thank you, sir. Thank you very much. Is it visible to everyone?
Yes.
Yeah.
Yes.
Thank you. Thank you. It's really an honor to have me here for this webinar. Thank you, ACNN, ACNS, Professor Kato and the team. So the topic today I have chosen is about the neurosurgical nurses, what a neurosurgeon expect from them. So role of a neurosurgical nurses is not only giving the instruments. If you look at their role, there are so many visible and there are so other invisible roles which are usually not seen. So especially I dedicate my lecture to all the nurses, because look at their roles. It's not only the OT efficiency or the sterility. It's not about maintaining a perfectly sterile operative field or anticipate smooth workflow. You see, they assist equally nicely all the time. They assist during all the cases, even in the complex situations. They help. There is like they are the patient safety champion, because they deal with this safeguard patient welfare before, during, and after the surgery, monitor for all intraoperative changes, the alarm systems, anything, and implement WHO safety checklists, etc. And most important is, they must have this commitment and discipline, which is the professional foundation of neurosurgical nursing. Regarding dedication to neurosurgery OT, excellence demands unwavering commitment. So what actually true dedication for these nurses? They have to be focused and specific commitment. A general mindset has no place in the operating theater. These nurses has to be completely dedicated to neurosurgery. They must have willingness to work long demanding hours with sustained mental concentration, proactive and continuous skill improvement through self-study, simulation, and peer learning. Equally have emotional resilience when something unseen circumstances occurs during the surgery. And pride in precision. Every response count, every instrument pass, every steps performed. And another very important aspect is their professional discipline, because among them, most important is punctuality and preparedness. OT should be set up when the team walks in, at least 15-20 minutes prior to surgery. Surgical team enters. We expect that they should be ready with the procedure which is going to be started. They should be ready with all the instruments and all details. Instrument trays prepared, checked, and counted pre-start, and anticipate the day's guest list and prepare accordingly. And they have to know the procedure before entering the operating theaters. They must, or what they are actually doing is stick to the OT protocol and ethics, because strict adherence to all OT protocols lead to very good result. And they have to equally respect hierarchies, and they have to take accountability for every action, and definitely ethical practice. Whatever the situation is, patients first, always. And communication standards, in any challenges, any circumstances, they should speak clearly. Clear speaking is very important, and with the confidence, politely, but firmly raise concern if there is definitely any safety violations, and written communications like OT records, accurate and legibility. And most important is whatever they do, it has to be documented. Unless you document the things, they are not taken as granted. So every instrument, sponge, and implant accounted for at all the times, document administration of drugs, fluids, blood products, never sign of counts you haven't personally verified, and report incidents honestly and without fear of blame. Second part is regarding their knowledge in sterile practice. They have to know, once any neurosurgical nurses enters the operating room, they have to know each centimeter of that room. They have to clearly know and identify what sterile zone is, what clean zone is, where microscopes should be kept, where other imaging like navigation or fluoroscope, whatever gadgets. So they have to know where these these gadgets has to be kept. And equally, they have to know where these emergency equipment are, and smoothly work through the coordination. Regarding the sterile technique, everyone knows, they know it very nicely, except there are certain conditions when, because of the hierarchy, many nurses, they fear to speak, but they have to be very rigid. When there is any contamination of the response, they have to address it immediate, calm declaration of any breach, and then ask them to remove, replace, or redrape, but never silently continued. And definitely, they also have equal role to inform the anesthesiologists or other doctors who are standing to give the like antibiotics or SSI prevention rules. They also need to know the surgical procedure knowledge, because every step before the surgeon makes the first incision. So step-by-step surgery knowledge has to be known nicely, because anticipation separates a good nurse from an exceptional nurse. So know every stage of each procedure on the case list. Study the evening before if it is needed. Even if you know the procedure, but if you study it for 5-10 minutes, the things will be very easier next day. Always anticipate the surgeon's next move and have the instrument ready before it is requested. Prepare procedure-specific instrument trays with 0 omissions. Missing an instrument mid-case is unacceptable. Understand possible intraoperative complications, ready for that, and debrief after each case. After, make habit what went well, what did not, what could be improved, what to prepare next time. Some general procedures like craniotomy, doing craniotomy, which is the most commonly performed neurosurgical procedure. So they have to help during the setup and positioning, head fix, skin draping, microscope position, drape, and zeroed before incision. Like for craniotomy, if you have to know that if it is the procedure of bone flap elevation, make sure craniotomy, kerosene rongers, bone wax are ready. If we are next step going to the dural opening, keep the bipolar, microscope, micro scissors, and cotonoids prepared. If there is surgery for tumor, hematoma, excision, make suction, irrigation, hemostatic agents, scusa, these things very ready. For the closure, dural suture, bone flap fixation materials, and skin staples ready. Again, for spine surgery, again, position is very important. You have to know you have to protect the eyes, and then keep the gadgets ready, like fluoroscope, arm setup for level confirmation, and skin prep and draping for posterior midline approaches. Like if it is the procedures, like if it is pedicle screw system, then have all different sizes of available and assembled. If it is laminectomy or discectomy, high-speed drill, curettes, Carrison punches. If it is spinal cord protection, continuous intraoperative nerve monitoring, and for the hemostasis, bone wax, bipolar, gel form, and thorough irrigation before the closure. For the tumor surgery, definitely the things which needs to be ready is a neuro navigation probe. Sterile, unsterile before the registration, CUSA or microscope, or frozen section for intraoperative pathology. And for the hemostasis and closure, all the hemostatic agents ready, like Surgicel, gel foam, flow cell, T-cell, cottonoids, bipolar setting, adjusters. For surgeon's performance before case, it has to be started from low, only on the request of surgeons, you can subsequently increase the bipolar setting. And definitely for dural closure, it has to be watertight suturing, sealant application if needed. For vascular neurosurgery, clip preparation is another paramount preparation. You need to know the details of different kind of aneurysm clip set, all sizes, applicators, removal, all this has to be very ready. And you have to know, you can separate the temporary from the permanent clip. Always before these vascular surgeries, it has to be loaded, temporary clip has to be loaded and available before dural opening, and papaverine irrigation all the time, and ICG to be ready, prepared for the intraoperative angiography. Vascular surgery is sometimes very challenging, massive bleeding. So those circumstances are really emergency ready. You need to be ready very urgently. For that, intraoperative rupture, like at least you have extra suction and extra cottonoids, get all these blood products cross-matched and available from the start of the case. And temporary clip use, time documentary is maximum, it's different, but remember, it should not cross more than 10 minutes. So these are the things, because surgeon is operating, he's keeping his eyes in the microscope, so nurses also has to look after such things and communicate blood loss calmly and continuously to the anesthesia team. Trauma neurosurgery is another very commonly performed surgery, and speed and precision makes differences in the life of the patients. So whenever there is a call for the trauma surgery, make sure you prepare the procedure for the procedure, everything ready within 15 minutes. And for that, you have to prepare a standard craniotomy tray, open, suction in bipolar, has to be tested, borrowed instrument front and center, speed is everything, blood and products, again, ready. In case of crisis, you have to coordinate. If there is massive hemorrhage, protocol, communicate with clearly to the blood bank if it is not there. If there is ongoing blood, then that time you can communicate in the blood bank to have extra blood products with. And definitely, as I said, suction, 2 large bore suckers running simultaneously. And but most important is calm and structured communication. No shouting, no panic, no hesitation. And it's the role of the circulating nurse is to document blood loss, fluid in time of events continuously. Pediatric neurosurgery, as it is said, this pediatric population is not the small adults. They are very different, very delicate. For them, all the instruments and everything are different and has to be prepared accordingly. Pediatric Mayfield, horseshoe heart rest, prone positions, temperature maintenance, pressure care. These babies, all bony prominences padded, eye protection critical, and definitely instrument sizing, use periodic trays. Adult instruments cause harm to this pediatric population. Third is they have to know all detail about the instruments and technology, because know every tool by name, function, and its limitations definitely has a great impact in the procedure. So Regarding the identification and preparation, name every instrument without hesitation. If you can't, study tonight. See, this is a simple principle. And procedure is specific tray layout, functionality check of, all the instrument, all joints move freely, edges sharp, bipolar tips clean, and inspect for the damage, corrosion, or incomplete assembly before every cases. Microsurgical care. This is very another important, because if it is if the nurse, the expert nurse does not it teaches this to the juniors, there is chances the microsurgical instruments they get damaged very early. So handle with extreme care. Microscope tips cost thousands to repair, and never clamp microsurgical forceps or drop on metal surfaces. Ultrasonic cleaning, it has to be ultrasonic cleaning, and store has to be in protective racks, never bundle loose in tray for sterilization. And regarding the core microsurgical set, you have to, these are the list of the instruments like microforceps, micro scissors, bipolar forceps, aneurysm clips, and specialty instruments includes dissectors, especially Roten set, which has to be cleaned gently, inspect tip geometry before use, suction tips, multiple bore sizes, cottonoids, different size, moistened, and all these cottonoids which are used has to be documented, and different size of the needle holders. And there are another. I will say they're the greatest driver for these power drills, like craniotomy and the drill. So load foot plate, test free rotation before draping. High-speed drill, select correct attachment, cutting, and diamond to stop whatever needed. Continuous irrigation, because otherwise it will cause thermal bone necrosis. And power cable has to be away from the sterile feed, no kinks or pressure points. Neuro navigation system, these are the tools which are used these days for all the cases, for most of the cases. And these are all the nurses has to know how to at least detail of this neuro navigation system registration. So pre-case preparation, registration process, attach fiducial markers as per hospital protocol, image upload and case creation, calibrate and workstation get ready for surgeons. And intraoperative maintenance is sterile navigation workflow, drift alert. If surgeon notes inaccuracy, pause and re-register it. Don't go it continues working without re-register it. And if there is a problem, troubleshooting, and always before the procedure, make sure your battery and the battery backups are ready. Regarding in case of the stereotactic system or neuroendoscopic, again, nurses has the greatest role. I always see while we put the frame application, these are the nurses who assist with pin placement and tightening, and also while they help attach these fiducials in the frame, and for the patient transfer with care to the CT or MRI room, and the arc entering trajectory assembled for neurosurgeon's plans with sterile tools and correct needle or whatever procedure is done, they keep it ready. Neuroendoscopic, before the procedure, again, they have to check these cameras, this irrigation system, all these instruments, and make sure this visualization is great. Another is OT technology and gadgets. Operating microscope, they have to know regarding these technologies and gadgets. Again, I discussed already. They have to know this operating microscope, how to drape, how to balance, and test before skin incision. Regarding CUSA, assemble, prime steps, suction, irrigation, and intraoperative ultrasound, probe draped, and get applied aseptically. Another role is patient safety and emergency response. because every protocol exists because someone didn't follow it once. So there are different positions and setups like supine. If it is supine, standard craniotomy, cervical, anterior, pad heels, and occiput. If it is prone, posterior fossa, spine, coordinate with anesthesia, log roll safely, left for the lateral, temporal approach, axially roll mandatory to protect brachial plexus, seating position. Air chances of air embolus is always there. So Doppler monitoring, anesthesia alert. And regarding the positioning safety, head fixation, confirm stability always before draping, nerve injury for the nerve injury prevention, uh, uh, ulnar, common peroneal, brachial plexus. Check at every 60 minutes whether it is they have ongoing extra pressure, eye protection, and confirm position has not shifted after patient moved or draped. Pressure injury prevention, it has to be prevented a different part of the body, different bony prominences. In case of face down position, foam cushions, avoid direct pressure on orbit in the chin, in the arm, any different aspects. And for the nerve and eye protection, for the eyes, corneal, average, and wrist, so tape close with gentle pressure. Sometimes you can use the this ointment on the eyes, and different pads. Another role is it's monitoring and neuroanesthesia. All these neuro operating nurses has to know these other aspects of neurosurgery also. Apart from the basic monitoring like ECG, pulse oximetry, or arterial or other capnography, they have to know this neuroanesthesia things also. How to maintain airway, how to keep the brain relaxed, use of mannitol, heat elevation, and mild hypocapnia. And also equally, they need to know the rationale behind these things. For cerebral protection drugs like propofol, thiopentine, recognized when being used, and temperature, keep the patient normothermia maintained all the time, active warming devices in case of the periodic cases. Another is neuromonitoring. There are many nurses who does intraoperative nerve monitoring. Alert criteria is amplitude. If it drops more than 50% or latency increases more than 10%, immediate inform surgeons. And if electrodes position pre-op, ensure no displacement during positioning or draping. Communicate neuromonitoring alerts calmly and immediately. They also have to know about the ICP and cerebral perfusion pressure, and raise ICP signs, CSF, how to do the CSF drainage, how to help if there is CSF drainage procedures, and if it is decompression preparation, mannitol, hypotonic saline, etc. There are these certain emergency conditions which probably all the neuro nurses encounter in their life, not only lifetime, almost daily lifetime. One is brain swelling. So, during the brain swelling, usually, again, I said the surgeon, they keep their eyes in the microscope site. Sometimes they cannot find the brain swelling, but these are the nurses who can see the other part of the brain. So they find it earlier than the surgeon. So immediate they then need to be rapidly communicate with the surgeon and inform that the brain is swelling, and inform them what to do, what do you need. And meantime, they can ask for transfusion of the mannitol or the hypotonic saline. And in case the swelling is getting worse, then prepare for decompressive instruments like and additional retractors, and sometimes the drainage of CSF. In case of intraoperative hemorrhage, two large bore suckers all the time running, and then extra cottonoids and hemostatic agents, Surgicel, Zelform, Fossil, etc. Ask for the blood products to start. If there is ongoing, then inform the blood bank to arrange more blood, and always document blood loss every 50 minutes, inform surgeon, anesthesia, and all other teams. And if even after these maneuvers, if the things are not under control, then definitely you have to call for the rapid response team and follow the rapid response protocol. In case of the intraoperative seizure, again, recognize it and protect sterile field. You have to protect whatever the seizure is ongoing or whatever the things is, always protect the sterile field and immediate ask for this benzodiazepines, lorazepam, diazepam, or levetiracetam, and whatever. And these drugs has to be available in the operating theaters. And now it's not only the neurosurgical emergencies. Apart from this, there are anesthetic emergencies like cardiac arrest, anaphylaxis, malignant hyperthermia, air ambulance. In such conditions, if there is cardiac arrest, call the team, start CPR and modify the position, get defibrillator. In case of anaphylaxis, adrenaline, get adrenaline, malignant hyperthermia, dantrolene protocol. For air embolism, flood operative field with saline, pack wound, call anesthesia immediately. And always there has to be emergency communication. Regarding the protocols, communication, and documentation, the paper tells saves patients and protects nurses. So this WHO surgical safety checklist, I think it has to be strictly maintained, and they are getting strictly maintained in all the cases. And these are the nurses again, they look after all these things. Regarding communication and documentation, it has to be, it is simply believed that what is not documented did not happen. So there are so many things nurses do during the surgery. I told my first that there are many seen and unseen things they are doing. So it is recommended strongly that all these things has to be recorded. It needs to be recorded, either it's intraoperative, pre-op, or post-op, needs to be documented. And another part is training, education, and research. The nurse who stops learning, they stop serving. So training and education and research has to go parallel with the work. So it's not that training is only from the senior, definitely they have to start training the junior nurses. So being a mentor, actively invest in junior nurse development, demonstrate procedures, teach sterile things, build confidence also, and building a learning curve, model professional behavior, share why behind these protocols. So clearly they have to tell them, create a psychologically safe environment for questions and mistakes, and document competency progression from a sign-off for each skill. Another is simulation and CME. We strongly, all these nurses also has to be participate in these simulation-based training programs, CME, and conferences. Like this, these are the nurses. Our department, we make sure that parallel with all the doctors, residents, all the nurses also gets the chances equally to participate, to present in all the conferences. So they actively participate and present in almost all the conferences. We take them always. These are the recently now we have four nurses. They are getting training, ACNN fellowship in Tianjin, and these are the pictures. And recently, two nurses had visited Taiwan. And if Professor Kato remembers, these nurses visited your hospital back in 2019. And few nurses went to India. So we make sure that all these nurses equally participates. So this is another the picture of many nurses where doctor and nurses team everywhere, they participate equally. And it's not that they only work in the hospitals, or they only present. We recognize them also. You can see in the pictures that Dr. Basanta Panta and past presidents, they recognize one of our neuro nurses. And the below picture is a group of the nurses. Again, they were recognized. And the right picture, and even when nurses visited and presented paper in AANS, Boston probably. Another, I said that simulation before before this stereotactic frame application, this is how the training should be, simulation program should be. So before the procedure, nurses and the other nurse, they practice, they know, so that they know these instruments better. Regarding research and publications, not only working and documentation, it has to be well evidence-based. So make sure that these nurses are getting involved in research. It never has to be like author or co-author. Sometimes collect structured OT data, like case times, complication events, protocol, and make sure to do these audits at least once a month. But it is recommended that if the audit is made every week, definitely the outcome is again different, and the things. And after you get the data, make habit to write and publish it. This is one of the recent paper from one of our nurses who participated in one of the original article, like functional neurosurgery for movement disorder, experience with deep brain stimulation and palliatomy at a tertiary care center in Nepal. I think we have many nurses who had published many original articles, case basis, so many things. This is the end of my slide. What we expect, what the world-class neurosurgical nurse has to be. Number one is knowledgeable. They must be master in anatomy, procedures, instruments, and technology. Second is discipline, right? As I said, it has to be follows protocols with precision and zero compromise. They have to be observant, notice before the surgeon does, act before being asked. It has to be very communicative, speaks clearly, documents accurately, escalates early, has to be resilient, steady in crisis, compassionate in setbacks. And the last is a lifelong learner, trains others, pursues research, never stops improving. Thank you very much.
Thank you, Prof. Rajiv Jha. Shall I call upon the commentators?
Hello.
Hello.
Prof. Nasir, thank you for joining us.
Good evening, dear Professor Lee, Professor Yuko Kato, and all my colleagues, and of course, my dear friend and brother in Egypt, Professor Ahmed Ammar. And I'm glad and honored to be part of this event, and thank you for the opportunity. I will not take much time. I know that we are three commentaries, and I just have 5 minutes. Let me start by saying what I believe. In the operation theater, it is a team. This team is a triangle composed of 3 pillars: the neurosurgeon, the neuro nurse or the operating nurse, and the anesthesia. For decades, one of these pillars had been ignored. Unfortunately, this has to be corrected now. And thanks to Professor Yuko Kato, who took the initiative since years, and she involved nursing in neurosurgery in all the events organized by Professor Yuko Kato and her team. Personally, since I organized the 14th Asian Congress of Neurosurgery, it was in December 2024, and I was the president of this Congress, and I had the honor to be the president of this Congress. I consider myself and my team to be part of the Asian Congress. And we organized under the leadership of you, Professor Yi, in Egypt, 2 successful sessions about nursing in neurosurgery. I can imagine how can a football team play without a goalkeeper. It's impossible. They will never win. Nurses in neurosurgery, they are the goalkeeper of neurosurgery who monitor and can help neurosurgeons to prevent complications inside the operation. And so I believe that collaboration is mandatory. It's inevitable. And in order to have a very good collaboration, we should have a very good communication. Because without communication, we will not achieve anything. I admire the talk of Professor Rajiv. Thank you very much. It's very, very impressive to me. I learned from your talk much. And I think it's very important to think about the future. Let us build up on what had been achieved by Professor Yuko Kato and her team. I think now we have a committee in the World Federation of Neurosurgical Societies about nursing in neurosurgery. And this is a very good initiative as well. And it was the idea of Professor Yuko Kato when I met her in Dubai. I think we need to augment all these activities. There should never be a single neurosurgical activity without nursing in neurosurgery contributing to this event. We have to make it as a rule because it's very important. Let them take part like 10% of the program. It is very important to stay in touch, to communicate, to work together, to understand each other. Because in the operation room, we are working in harmony. We have to understand each other better, and this will never be achieved without having a proper communication. Not only all neurosurgical congresses and webinars and events. What about neurosurgical research? They have to be part of this research as well. Right now, there is a barrier, and the barrier is still existing between neurosurgeons and nursing in neurosurgery. We have to destroy this barrier as early as we can. What I also believe that the next step, we have to encourage the students in neurosurgery as well. This is very important. The students should know how are we working, how they are going to take our specialty if they know nothing about our specialty. And I would like Professor Yukoka to adopt this idea as well, because adopting the idea of nursing in neurosurgery done by Professor Kato was successful. I think the next step that we have to think about is how to involve students in our specialty and work together. They should be involved also in all neurosurgical events and neurosurgical research. Thank you very much. I will not take much of your time in order to give opportunity to my dear colleagues, the commentators. Thank you.
Thank you, Prof. Nasir. The other 2 commentators, Prof. Kwa and Ms. Apita.
Can I go? Can I give my comments?
Yeah, please.
Okay. Thank you, Professor Jha, for your wonderful presentation. And you have talked on a topic that is very close to our heart. That is, your expectation for a nurse. I am by profession a nurse, of course. You all must be knowing. So neuronursing extends beyond the routine patient care. So if a patient after post-op, you have sent the patient to ITU for continuous monitoring and all. So a nurse basically takes an opportunity or identifies if there is any issues with the patient, if there is a deterioration, and immediately that collaboration and communication, as Professor Nasir has already told in his comment, that the nurse, picks up that slightest hint and acts on it. So that's a huge communication that they have to do on a daily basis. Now, what stood out the most in your presentation and Professor Nasir's comment, that teamwork and communication goes hand in hand. Without teamwork, it is quite impossible. And what Professor Nasir also has commented, that the student nurses has to be involved. I know it's a very high pressure, environment inside the OT, and a nurse has to do basically to ensure that, whether your OT room is cleaned in between surgeries or not, whether the time gap has been maintained or not, to, assisting you in a very complicated surgeries. So I understand the nurses' expectation is also a huge from surgeons as well. So if there are some gaps or lacunae, I believe the nurses also expect you to guide them and teach them where are the faults are. So here lies the collaboration between the surgeons and the nurses. And there are many specific or specialized areas where the nurses can focus. As for example, you were talking about neuromonitoring. So in our hospital, we do have a specialized person who only looks after the neuro monitoring part and not the nurses. So in that way, I believe this, interprofessional collaboration is going to help us in building the nurses' capability and all those things. Another point I want to mention, Professor Rajiv, it is regarding the surgical safety checklist. I just want to mention that this is not only a nurse's responsibility. Most of the time in many OTs, what I find, it is only the nurse's responsibility to conduct the surgical safety checklist. I think it's a collaborative effort, and the surgeon should not proceed with his scalpel without, calling it that you have to do it, no matter who you are, you have to do and go ahead with the surgical safety checklist. So these are my comments from my side. And thank you, Dr. Rajiv, for your wonderful presentation. Thank you, Ms. Yit, for communicating with me to be a part of this wonderful and prestigious platform. Thank you so much. You're mute, ma'am.
Prof Igua.
Yeah.
Prof.
Hi. Yeah, I'm here.
Yeah.
And yeah, thank you, Mei Chen Yi, and for inviting me to attending this webinar. And it's my honor to be here. And I'm Dr. Yi Guo from Beijing Tsinghua Changgeng Hospital. And the Professor Rajiv's lecture is impressive and excellent presentation. And I totally agree with the professor's lecture. And for our neurosurgeon, we have to remember all the time the teamwork is the most important thing between the neurosurgeons and the neuro nurses. We are the one team. So we work together for every day. And from neurosurgeon's perspective, we expect nurses to act as our eyes and ears at bedside. And in the operating room, we expect all the procedures are fluent and no gaps. And especially we expect the neuro nurses uh, to notice the subtle neurological changes that may signal early postoperative complications. And so these close observations and good communications with the neurosurgeons is for the patient's safety and sometimes life-saving. And but for like neurosurgeons, I think the neuro nurse, the their career is a journey of the continuous learning. So many basic principles and protocols, and pathophysiological theories and medical equipment parameters must be mastered and interpreted, and also need to keep updated the knowledges. So And we recommend the nurses to do the attainable small scale on the job training programs and during daily rounds to improve nursing skills. And in our hospitals, in all operating room, the senior nurses ask the trainees to take notes before surgery to make sure they understand the procedure well and good preparation. Uh, and we'll ask the trainees to go over the problems and the steps not fluent during the surgery to make sure not happen again. So, uh, I and like the but in the uh, developed countries, they have more resources for the nurses training. But in resource limited areas, I think it is a big problem for the nurse training and improve their skills. So the Professor Kato and Mei Chen Yi devoted and their every effort to improve, to create the chances for the nurses training and international communications. So just like the Professor Rajiv showed in the presentation, they send nurses to the Tianjin, Huanhu neurological hospitals. And last year in my center, Mei Chen Yi sent three uh, nurses to our center for the visiting program. So we want to share our experiences and to do more for the ACNN. And that's my comment. And thank you. Mei Chen Yi, you're muted.
Sorry. Prof. Gopa, anything to add on?
Yes, of course. Yeah, it was a very interesting and dynamic webinar. Lots of discussion regarding this nurses' duties. So what I feel is that you see the nurses are our backbone, are the pillars, right? And without them, we can't move. We need them from OPD to ICU, OT, ward, everywhere. We need them. And they should be proactive, disciplined, smart, knowledgeable, so that everything will go in the proper way. The result should be, the outcome should be better. So for that, so we should train them, we should send them for workshop, seminars, and arrange some, this presentation webinars like this. And other thing is that, and they need some incentives, right? We just ask them to work. If we don't give them anything, that's not, good. So sometimes they should need incentives for that. Our department should something to give them some good gift or something like that. They should be recreated. We should arrange for the picnic or recreational party so that they feel happy. And you see, and oh, what I want to tell everybody is that they need our support, help, and love, right? So that they go very well and they become one of the best neuro nurses in the world. So we should help them from every aspect. So I would like to thank Dr. Rajiv for giving such a interesting and informative presentations. And I would like to thank you and Professor Kato and all the organizers for arranging such a, nice webinar. Thank you so much, everybody, all the participants, presentators, and the AANS.
Thank you, Prof. Gopal. Prof. Yoko Kato, do you want to add something?
No,
Prof.
already,
Kato?
yes. Hi. So thank you very much, Gopal, and also the three commentators. So the same opinion, the Dr. Rajiv. Thank you very much for the great talk.
Yeah, thanks so much.
Yes.
Thank you.
Yeah. So his talk very details in every variety of the nursing, the role for the neurosurgery. So all of them is very, very important. Recently, we have more endoscopic or more sometimes endovascular. So maybe I think, of course, in your country, maybe you will have more cases, I think, than us. So please take care of those the patients. Thanks so much.
Thank
Yeah,
you, Prof.
thank you.
Kato.
Bye. Bye, everybody. Bye.
Bye. I hope with the support from all the neurosurgeons, we'll get more centers will accept neuro nurse fellowship training. So in future, I think more neuro nurses from the lower country will be able to join. So can I now call upon Christine to take over the second session?
Thank you, Ma'am Yi. Can you clear my voice clear, Prof? Okay. Thank you for all. Good evening from me for the Professor Kato from Indonesia. And I would like thank you for commentator and speaker. We will now move to the session 2. This session will be chaired Prof. Ahmed Amar, our distinguished speaker, Professor Danilov Gleb, will deliver a presentation entitled The Impact of AI in Neuronursing. And we are also honored to have Professor Nasir and Professor Miguel and Ms. Arpita also as a commentator for this session. I would like to invite Professor Ahmed Amar to lead this session. Professor Ahmad, the floor is yours. Thank you.
Yes. Thank you very much, Ms. Christine. Thank you very much, Dr. Kato and Dr. Nasser Ghandour and all my dear friends and Dr. Yi Chang. It's an honor and a pleasure to be with you again and looking forward to more participation in your activities. Well, I am not taking more, but I think next subject is very, very important subject actually, because we are actually on the edge of major changing, not only in neurosurgery, but in the world. And the history will be really written. New surgery and medicine before AI is different from medicine after AI. So we are lucky to have a very good speaker and researcher, Professor Gleb Danilov. He is an MD, a PhD neurosurgeon. He is also a clinical researcher, biostatistician, statistical and programmer, with data scientist and software developer. So he is really a scientist and a good neurosurgeon. He is working in Bronduku Hospital in Moscow, and he has several publications, and he has also some research with some pharmaceutical companies in the state. And actually, if we talk about him, you can talk a lot. He has also a human and culture activity, very wonderful activities he has. It's a pleasure to introduce you, Dr. Gleb Dandolf, and the floor is yours.
Thank you so much, Professor Amar, for such a kind introduction. I will share my screen to start the presentation. Can you see my screen in full mode? Hopefully, yes. Thank you.
Yes, yes, Prof.
Thank you. So, dear Professor Kato, dear Matron Yicheng, dear Professor Amar, dear distinguished chairs, moderators, and discussants, thank you so much for this honor of speaking today. My presentation will explore the impact of artificial intelligence on the specialized field of neurosurgical and neurological nursing, and I want to say great thank you to Professor Rajiv Jha for such a nice introduction of neuro nursing. When I speak about artificial intelligence in neurosurgery, I usually try to illustrate my points with our research data coming from the Laboratory of Biomedical Informatics at Burdenko Neurosurgery Center. But today I'm breaking this habit in discussing the impact of artificial intelligence on nursing, especially neuronursing. I want to focus less on the present and more on future, and you will certainly notice it in my slides. Why? Because let's be honest, while artificial intelligence is obviously changing our daily lives through at least large language models, chatbots, voice assistants, facial recognition, you name it. It is not yet but it's not yet the gold standard in medical care. Much of this technology is still in the development and testing phases. Furthermore, we're just beginning to navigate to complex ethical and legal questions surrounding the use of artificial intelligence in medicine. So today, let's explore these challenges together. Before examining a specific application, it's helpful to define a working concept of artificial intelligence. So broadly speaking, artificial intelligence encompasses computational systems designed to mimic human cognitive functions, such as visual pattern recognition, natural language processing, reasoning, decision-making, etc. But can a collection of isolated cognitive functions truly equal to the human brain, or even represent a higher form of intelligence? In my view, that is technically impossible now. In my view, it's impossible. But more importantly, developing AI with the explicit goal of replacing humans is fundamentally unethical. Crucially, we must approach AI as a tool for augmentation rather than replacement. I want your thoughts, whether you agree with me or not, but the primary objective is to offload data-intensive tasks to machines, thereby allowing nurses to reclaim time for the fundamentally human aspects of care, for empathy, for ethical deliberation, and complex clinical judgment. Why is AI particularly relevant to neuronursing? Well, the field of neuronursing is largely defined by critical windows for interventions. Whether managing an acute stroke or monitoring intracranial blood pressure, the volume of complex clinical data is immense. And the stakes are exceptionally high. By translating even contemporary AI tools in neurocritical care, well, we may potentially achieve a new level of precision in evaluating of neurological recovery and post-operative care. So my objective for this session is threefold. First, to identify the key AI domains applicable to neuronursing workflows. Second, to critically evaluate the current maturity and clinical validity of these tools. And third, to address the barriers and ethical consideration we must navigate to guarantee patient safety and professional ethics. Artificial intelligence has practical applications, potential applications, and real applications across the entire continuum of neuronursing. And we are seeing its impact, and we can potentially see it in future at every single stage, from preoperative stage, preoperative preparation, intraoperative support, right through post-operative care and rehabilitation. So let's look a few certain ways AI is already reshaping our clinical workflow and potentially may reshape. First is advanced imaging analysis. We now have algorithms capable of detecting incredibly subtle lesions or vascular anomalies on MRI and CT and PET scans in a matter of seconds. Of course, this doesn't replace our expertise, but that technology, including computer vision and radiomics, brings additional digital information, and it drastically reduces the interpretation time and acts as a powerful second set of eyes, which is important. The second thing is risk stratification. By feeding a patient medical history, lab results, imaging biomarkers into predictive models, we can accurately assess their risk for surgical complications before they even enter the operating theater. You may ask, why do you need this prediction? Why do you want to predict the outcome? The thing is that, of course, we cannot predict the future, but we can stratify risk. We can say that for this certain patient, we can measure the risk or refer this patient to a certain risk group. And that could be important for the further tactics for the whole management. Finally, automated triage. In neurology, time is everything. AI systems can continuously analyze baseline data to automatically flag and prioritize our highest acuity patients, ensuring that those who need immediate intervention get it without any delay. In the operating room, precision is absolutely demanded. Well, we do not know what a precision in neurosurgery is, but we always try to evaluate it, to assess, to measure. And there is where artificial intelligence can truly shine by providing real-time intelligence and significantly reducing the cognitive burden on neuronurses, as well as on neurosurgeons. Let's look how can this work in practice. So first, through real-time monitoring. AI systems can continuously track vital signs, EEG patterns, cerebral oximetry, ICP, ABP, etc., etc., etc. So they act as an early warning system, alerting nurses to subtle deviations long before they escalate into some critical emergencies. Second, we can see the benefits of robotic integration. So AI-assisted systems can help nurses manage complex instrument workflows, which minimize manual errors and boost overall surgical efficiency. That is a very good goal of using artificial intelligence in medicine to increase precision and to reduce errors. Third, and perhaps most importantly for daily practice, AI can drastically reduce cognitive loads and mistakes referred to connected to this cognitive load. Now, by automating intraoperative documentation and utilizing smart alerts, nurses are freed from the screen. They can focus on what matters most, patient-centered care rather than paperwork. Finally, AI facilitates seamless communication, ensuring that critical real-time information flows effortlessly between surgeons, anesthesiologists, and nursing staff. A major domain, of course, in artificial intelligence and medicine is clinical decision support. So AI systems can assist nurses in assessing patients' acuity and prioritizing care. In neuronursing, AI technology may be utilized to create early warning systems, not only in the operation room, but in a post-operative facilities. So consider an AI capable of analyzing subtle trends in routine neurological assessments, such as precursor signals of vital signs deterioration, or even a marginal change in pupillary reactivity or slight decline in the Glasgow Coma Scale, alerting the clinician well before a catastrophic event occurs. Regarding patient monitoring, AI-driven wearables are already demonstrating success in reducing ICU readmissions from general wards. In the Neuro ICU, this technology can also be applied to continuous ICP, ABP, EEG monitoring, rather than merely responding to threshold alarms. AI algorithms can analyze complex waveforms to forecast pressure spikes minutes before they occur, so facilitating proactive rather than reactive intervention. And I want to stress that proactive vs reactive. Furthermore, human signals, predictive analytics of human signals enable to forecast patient outcomes by synthesizing heterogeneous data streams from electronic health records and bedside sensors. Unfortunately, no doctor can operate with this amount of information in his or her mind. For a neurosurgical nurse, this capability of artificial intelligence facilitates the early prediction of post-operative complications such as cerebral edema or hemorrhage or any other complication by identifying subtle physiological patterns that may be imperceptible to the human eye. You will tell me that that sounds like fantasy or it's fantastic now. Of course, it can sound as some fantastic vision or perspective, but we do not know what we will face tomorrow, and this future is highly probable. Another highly practical application involves large language models, or LLMs. So recent research demonstrate that these models can assist in formulating high-quality nursing diagnosis and comprehensive care plans. In the context of neuronursing, this enables to utilize structured templates to generate disease-specific care plans for complex scenarios such as post-craniotomy recovery or spinal cord injuries, whatever, ensuring that no critical intervention is overlooked. Just imagine a dialogue between a patient and a nurse, between a doctor and a nurse. This dialogue is heard by a special AI platform that is transcribing this dialogue into unstructured text. Then large language model structurizes, summarizes that dialogue, and shapes a primary medical document without any typos, rather literal and grammatically correct. That is not the future. That is the present day. At Burdanko Neurosurgery Center, we also work on that technology. Post-operative neurocritical care demands constant, unwavering vigilance. So human attention has limits. This is where artificial intelligence steps in, potentially transforming the Neuro ICU from poorly reactive environment, as I have already said, into a predictive one. So consider intracranial pressure. Instead of waiting for an alarm to sound when ICP is already dangerously high, machine learning models can predict these events 30 to 60 minutes before they happen. You will tell me that's not absolutely precise prediction. Of course, but that is better than no prognosis, no prediction. And this gives nursing staff a crucial window for preemptive intervention. Furthermore, predictive analytics enable doctors and neuro nurses to forecast patients' outcomes, synthesizing heterogeneous data. And that is also important in many many aspects. And one of the most taxing parts of neuronursing is physical mobilization of patients with paralysis or with severe motor deficits. That is another domain of using artificial intelligence in neuronursing. AI nursing robots and exoskeletons, they are emerging to alleviate this burden on neuronurses. These tools do not replace nurse. They act as physical force multiplier. They are kind of amplifiers. So they reduce nurse burnout and injury while helping the patient regain mobility more safely. Another one burden I would mention is the burden of clinical documentation. Is a universally recognized challenge worldwide. Robotic process automation, or RPA, is specifically designed to manage high-volume repetitive tasks. In neuronursing, automating the transcription of hourly neurological assessments or fluid balances can significantly reduce the administrative burden on nursing staff, thereby redirecting their focus and time back to patient care, direct patient care. Artificial intelligence should also transform clinical education. For instance, AI-driven chatbots have been successfully utilized to simulate urgent paging scenarios for medical students. We can adapt this technology for neuronursing residency programs, developing high-fidelity simulations that allow novice nurses to practice responding to acute neurological emergencies within a risk-free digital environment. So there are lots of devices and technologies that can be helpful for smart recovery and discharge planning. And you can see it on the slide. Wearable technology that I have already mentioned that can continuously tracking motor function, gait, heart rate variability, sleep patterns, etc. Personalized rehab protocols that can be tailored by AI, so physical and cognitive therapy plans in real time based on patient progress and response data. You will probably say that, you will probably ask, can we really rely on AI generated protocols? I think if they are validated by humans, that can be a good instrument. Virtual patient assistance, chatbots supporting symptoms checking, medication reminders, answering common post-op questions. That's a tricky point. I mean, nowadays chatbots are not that knowledgeable, are not that professional to be an expert to communicate with patients, but we don't know what will happen in future. So I wouldn't recommend to use any ChatGPT, any unspecialized generative pre-trained model to communicate with patients to operate as an expert. But we should think of developing such large language models for specific neurosurgical, neuronursing tasks. And of course, readmission prevention, remote monitoring, that technology is working today, and alerts coming from AI assistance, mobile assistance that can reduce really readmission rates and prevent heart complications. So to summarize this section, you can find some information on the screen. So on the left, we see some general AI applications like administrative RPA or wearables. On the right, you can see some neuro-specific extrapolations such as automating neurochecks, predicting ICP spikes, etc. So this transition from general to specialized is where the true value for patients may lie. Let's continue with the critical question that artificial intelligence brings to us. What is the current readiness level of this technology? At present, AI integration within nursing practice is largely characterized as minimal or restrained, although the clinical potential is substantial. The majority of these tools remain in the pilot phase, evaluated in localized cohorts rather than being established as the standard of care across healthcare systems. When examining the current literature, I think the primary limitation is methodological heterogeneity. The existing studies vary too widely, and they're designed to permit some definitive meta-analysis. Consequently, there is an urgent need for more nurse-led research focused on real-world clinical workflows, moving beyond the constraints of controlled laboratory settings. And today, we have already talked about the necessity to involve nurses into clinical research. That is absolutely fair for AI research in neuronursing, in neurosurgery and neurology. If we stratify AI technologies by readiness, I think administrative tools and basic LLM assistance for documentation fall into the high readiness category. So you can believe that large language models can do a perfect work with a perfect paperwork, a perfect processing of documents. Conversely, fully autonomous robots or AI systems designed to make critical clinical decisions without human oversight remain at low readiness, as I have already mentioned. We are currently operating in the era of AI assistants, but not autonomous agent, and the role of doctor is crucial, and the doctor can be substituted, and the nurse cannot be substituted, and the doctor cannot be substituted by that type of technology. Currently, two major technical hurdles impede a widespread adoption of artificial intelligence. The first is interoperability, the persistent challenge that disparate hospital software systems often cannot communicate seamlessly. The second is black box phenomenon. So in many implementations, AI is a black box. We cannot interpret how it works. If an AI alerts a nurse to patient deterioration but cannot articulate the underlying rationale, it becomes exceedingly difficult to trust that algorithm in a high-stakes neurosurgical environments. But beyond technical barriers, we must also consider human risks, particularly skill erosion. If we become overly reliant on AI to detect physiological changes, we risk degrading the clinical intuition, the sixth sense that experienced nurses cultivate over time. Furthermore, we must actively ensure that AI integration does not lead to dehumanization of care. While a machine can monitor neurological parameters, it cannot provide human comfort. Ethical considerations remain paramount, particularly regarding algorithmic bias. If an AI model is trained on datasets that fail to represent diverse populations, its clinical recommendations may be skewed or inaccurate for marginalized groups. And that is one of the problems of wide adoption of artificial intelligence in medicine. Additionally, the unprecedented volume of continuous data collected by these systems raises significant concerns regarding patient privacy and institutional data security. And simultaneously, the legal landscape is struggling to keep pace with technological advancement. If a nurse acts upon an AI recommendation that ultimately results in an adverse outcome, the allocation of liability remains ambiguous. Who is wrong in that situation? Does responsibility lie with the clinician, the software developer, the nurse, or the healthcare institution? So many questions. Establishing robust legal frameworks is a prerequisite for the full integration of these tools into clinical care, and the development of this legal field, ethical rules, and technology shoulder by shoulder is absolutely important. As we look to the future, we must remember that AI can significantly improve medical outcomes, neuronursing outcomes, but only if being implemented ethically, collaboratively, and with the nurse at the very center of its design. So the goal of using artificial intelligence here is augmentation, not replacement. We want AI to handle the heavy lifting of data analysis so that nurses can return to handling the patients. To make this reality, education is key. We must integrate AI literacy into nursing curricula so the next generation of nurses is prepared to use these tools effectively. Furthermore, we must put ethics first. Transparency, bias mitigation, patient consent are absolutely needed. Ultimately, the future of neuronursing probably depends on the synergy between high-tech artificial intelligence and high-touch human compassion. Having explored the real and potential clinical applications of AI from the pre-op stage to neuro rehabilitation, we must now turn our attention to the practical reality of implementation. It is one thing to develop an algorithm, but it's entirely another to integrate it into a high-stakes clinical workflow. We'll try to examine the primary barriers to AI adoptions in neuronursing, the strategic pathways we can take to overcome them, and ultimately what this technological shift means for the future of profession. So what prevents the biggest adoption of AI in our words? I have already told the part of the answer to that question. Of course, the first problem is the maturity of technology. If the maturity directly influences the trustability of AI technology, and immature AI will never be demanded, nor by doctors, neither by nurses. Also, there might be a significant knowledge gap. Contemporary nursing curricula largely lack formal training in AI literacy, as I have already told. So second, there is a notable cultural resistance, pervasive apprehension that technology may displace clinical roles or disrupt the fundamental sacred nature of nurse-patient relationship, so that technology can really transform the future of profession. To achieve successful integration, we must adopt a phased approach, so initiating targeted pilot programs, monitoring key performance indicators such as nurse satisfaction, which is absolutely important for using AI technology, and subsequently scaling successful models. Crucially, nurses must act as co-designers. They must be deeply involved in the process of AI technology development. We cannot merely be end users of AI. We must be actively involved in the design and clinical validation of these tools to ensure they seamlessly integrate into real-world workflows. Looking to the future, we can envision the emergence of precision nursing. Rather than relying on standardized protocols for all postoperative neurological patients, AI will enable us to tailor interventions based on each patient's unique recovery trajectory. We call it a personalized approach. We will transition toward a seamless ecosystem where bedside monitors, electronic health records, and mobile clinical devices function as a single integrated unit. Ultimately, the fundamental role of the nurse is undergoing a paradigm shift. We are transitioning from being just mere data collectors, spending countless hours on manual documentation, on working with data manually, to becoming an AI information managers and human-centric care coordinators. At least I would consider this paradigm the most valuable. In this new paradigm, the machine processes the data, allowing the nurse to focus entirely on the human being. In summary, AI offers transformative potential across clinical decision support, real-time monitoring, robotics, administrative automation, etc. By translating these technologies into neuronursing practice, we can significantly mitigate cognitive workload by enhancing the safety and care of most vulnerable patients. And if there are only 3 key takeaways from today's session, let them be these. First, AI is a tool for clinical augmentation, not professional replacement. Second, AI literacy must be integrated as a core competency within nursing education. And third, algorithmic transparency, ethical oversight, and non-negotiable prerequisite are non-negotiable prerequisite for patient safety. In conclusion, the integration of AI in neuronursing is not merely a possibility. It's probably is an inevitability. So, however, its success hinges on maintaining a critical balance. We must embrace high tech to achieve unprecedentedly efficiency and precision, while simultaneously elevating high touch to preserve compassion and human dignity. So this synergy, I hope, represents the future of our profession. Thank you so much for your time and attention. Thank you.
Christine, can you take over the session, Christine?
Yeah. Thank you, Professor Danilov. May I first invite Professor Nasir
Thank you.
to provide his comment and suggestion, Prof. Please.
Thank you, my dear professor, for introducing me. And I would like to express my great pleasure while listening to the talk of Professor Danilov. It was really impressive. And I think we all learned from this presentation. It's well organized, especially the part when you spoke about the role of artificial intelligence inside the operation room. And my understanding that it has 4 jobs. And let me start just by asking you about what's going on currently now in the world. As you said that it can help in real-time monitoring, robotic integration, and we know this, and we know that it started in Japan and it's activated in Japan as well. And number 3, the automated intraoperative documentation. And number 4, the AI-powered communication platforms. And how can these help neurosurgeons? Is it already available in some centers all over the world? Concerning the 4 points, if you allow me to just learn from you, I will be grateful.
Thank you so much, Professor Elandur, for that questions. I can say that this technology is emerging, and there are some centers in the world that use that technology. They develop that technology. As regarding to our Botanical Neurosurgery Center, we are now developing the same technology for predicting outcomes, for monitoring vitals, for analyzing unstructured text using NLP, natural language processing algorithm, and large language models. For instance, in our center, we have a special supercomputer facility, and we now use large language models to monitor complications, so to screen electronic health records and find specific parts of unstructured text to conclude about the presence of meningitis, hematomas, pulmonary embolism, etc. We also use this technology to structure unstructured medical records. For instance, there are some voice assistants widely spread, worldwide spread, and you even have it in a mobile phone. But medical voice assistants is something very special because the data is very sensitive in medical facilities. So we have developed our own voice assistants that is constructed from 2 models. The first one transcribes the voice, the speech into text, and the second one structures it, summarizes it, and prepare a documentation. And there are lots of such examples of working with medical documentation worldwide. However, artificial intelligence is not an mainstream now, but it emerges very fast. It emerges rapidly. And today we'll say that this technology, we would say that this technology is under development, but probably tomorrow we will know that almost every neurosurgeon and almost every nurse uses AI. It's so fast, it's so rapid.
Thank you very much. And let me tell you my opinion and my comments. I think right now the most important benefit for using the artificial intelligence is in training, and we would like to introduce AI in the training centers as much as we can, whether simulation, augmentation, or any types of training. And the second thing, and I think the most benefit goes to the specialty of radiology. Because when you think about the machine learning, and especially the deep learning, it did a revolution in the specialty of neuroradiology, and we can see hundreds of publications about AI already used, augmenting and scrutinizing the evaluation of the neuroradiologists. And that's something very important. But I want to say, and it was your conclusion at the end of your talk, that such technology is indispensable and it has unlimited capabilities, but it has to be used in the proper way. Because right now we can see patients going over the GPT, for example, they are scanning the MRI image, they are putting the image, and the AI answers what to do. The AI can provide treatment, not only advices. And in my country, we are starting a project since about 3 years. We are putting guidelines about treatment of anything in all specialties in medicine. And I'm chairing the committee for neurosurgery, and we already publishing our guidelines in the treatment of any disease, any neurosurgical disease. And this project is done in collaboration with the WHO. And I have seen a comment from one of the members of this committee, which I'm chairing, saying that some patients using the GPT in order to get a medical advice, and they can take treatment. What's the value of the guidelines we are doing as neurosurgeons? If the GPT is going to replace the guidelines, it's going to be extremely dangerous. I think the second point which should be taken into consideration as well, we have seen lot of publications, lot of innovative softwares. Really, it was very, very useful. But we have the problem that such innovative softwares, most of it are protected by intellectual property. And so this is going to hinder scientific reproducibility. It's going to hinder benchmarking, and even it can hinder external validation. Such things should be thought about how to overcome or how to make a balance between the intellectual property and between the scientific reproducibility in order to progress and to use the artificial intelligence in the best way and as maximum as we can as neurosurgeons. Thank you very much.
Thank you, Professor. I would like to invite Professor Ahmed Amal to share and comment.
Thank you very much. I really enjoyed very much the presentation of Dr. Danilov and the comment of Dr. Nasser. In fact, my last book published a year ago, The Future of Neurosurgery, has at least 20 chapters talking about AI. The problem is, which I can see, we saw the starting of the emerging of the AI and the implementation in medicine, but we haven't seen the end of it. We are not even near the end of it. I think that is we have to be in the time not to wonder about what we have, but really to be prepared to use what we have and try to expect what is coming on. I could see and I agree personally from the bottom of my heart that AI and robotics are not replacing nurses or neurosurgeons. However, Elon Musk, he thinks it's the opposite. He thinks is within 5-10 years, robots are going to replace humans in different ways. So I think that is a problem. I don't say that he's right. I don't say that's wrong, but I think the task is our education and the training system has to be changed. We have really to teach the student and young people how to work with the AI, how to work with the robot, how to expect what we don't expect at the moment to come in the future and deal with. AI definitely has a great benefit, as all of you said, and is already in use in many things, like documentation used as wearable materials, and also as radiology, decision analysis, many, many things. And the great benefit, of course, which you use as customized medications. Now that is, we don't give the same medicine to everyone, but we can customize the medication to each one according to his general condition. Robot surgery proved it has a benefit. So many things to come. I think it is a task now. We have to change our mind from fighting and say, no, AI is not going to replace human, to something we have to learn how to use the AI, how to work with the robot, how to expect what we don't really see now, what will come in the future. It is a problem. It's not only the problem of the technology, but it is the problem of our mindset. We have to change our mindset. We have really to accept the changing which is coming. And changing it is not from our established consultant, but it has to go down to the medical school. We have a very small experience now in my new faculty of medicine. We started actually in the first year in the medical school as adding what we say additional courses about how to get the AI in studying anatomy, for example. How AI can help in studying hematology, how AI can help in studying pathology, how AI can help in diagnosis. And I found the young students are really very active in it, liked it, and even started to go beyond what we think about. This is the future. We have to work with the AI. It is a fact. It is coming to stay and coming to progress. And we have to change our mind from education point of view, from practical point of view, from actually research point of view, to use the best of AI. Problem which Dr. Danilov said, ethics. And also in my book, I made 2 chapters about ethics. Even the ethics has to be really changed in one way or another. But ethics will remain. Patient is the center of care. That is, everything has to be done for the sake of the patient. Every adoption of information or technology has to be for the patient. This is what we call values-based medicine. And that is really something has to put it in mind, and it has to make a lot of courses, a lot of workshops. As we are talking about AI, we talk about values-based medicine and how we can take care about the ethics of it. Point which Dr. Danilov said correctly, accountability. If the robots made a mistake, who is accountable? If it's that is a customized medication was wrong and killed the patient, who is accountable for that? There are a lot of questions still. I don't want to take more time, but I really enjoyed very much the session, and thanks to Professor Cato for coming up with such great idea to have such session about AI, and I believe we need more. We need more session about this. Actually, I wrote something and I love to present one day about the dark side of AI. Yes, we have a good side, but we have a dark side also. We have to highlight on it. We have to talk about it. We have to be prepared for it. Thank you very much.
Thank you, Professor Amar. And I would like to invite Professor Higu to share his comment and suggestion. Professor, please.
Yeah. Thanks, Christine. And thanks, Professor Danilov. And this is a very interesting and a meaningful topic. And I'm enjoyed your presentation very much. And over the past 100 years, neurosurgery has experienced about the 3 stages, like a classic neurosurgery, microneurosurgery stage, and minimally invasive neurosurgery stage. And now we are entering the digital and intelligence neurosurgery era. And I think AI is a storm, and we cannot resist it. And so we have to embrace it. And especially for the younger generation, we have to understand its advantages and disadvantages. And AI is powerful, but it is only a powerful tool. So I totally agree, Professor Danilov's repeatedly emphasized point. It should be a human-centered and like the high touch, the professor said, it means the human touch, I think. We need to ensure the human touch still remains the focus and not allowing the technology to create an emotional distance between the medical workers and the patients. Thank you.
Thank you, Prof. Higu. And I would like to invite Ms. Arpita. Any
Thank
comment
you
and
so much.
suggestion?
Yeah. Thank you so much. Thank you, Professor Danilov, for a wonderful presentation. Well, we cannot really get rid of AI. We have to work with it because it's the future. And I really appreciate the ethical and legal consideration you have talked about. You have talked about the black box problem. I have noted it down. So it's a deep learning models that makes autonomous decision, and why it makes it even the creator don't have the answer for it. So whoever is using AI, I think they should use it logistically, and they should have application of their independent clinical judgment as well. Otherwise it can be very harmful, as Dr. Ahmed already talked about it. And data sensitivity, we need to keep in mind also that data sensitivity, that is mishandling of sensitive patient data used to train the algorithm, it can be very dangerous as well. However, in my conclusion, I just wanted to say that AI is not going to replace nursing, because once again, the empathy, the touch that we are talking about, it's very, very essential component of the nursing, and it is going to help us. And we need to invest our time and interest in AI so that we can build a better version of nursing as well. Thank you so much. Thank you for your wonderful presentation.
Thank you, Ms. Arpita. Thank you for commentator and support for the chairman as in the session 1 and session 2. And then please, Prof. Ahmed, for the closing remark. Thank you.
Thank you very much, Christine. Thank you very much, Dr. Danilov, Dr. Nasser, Rebita, and everyone, and of course, Dr. Koto, to give us such a chance. I really enjoyed thoroughly this meeting. This meeting, it is one of the, for me, is one of the very best meeting. The presentation of Dr. Danilov about the artificial intelligence and how it became a fact and how it is present, is not in our work, and how it is used and implemented in decision making, in documentations, in radiological analysis and data analysis and data collecting and wearable software and many things and deep things, and how it is used in the OR, used in the ward, used importantly in the ICU as well, and used actually in outpatient clinic and giving dates. All these things happening now. But as I said before, that is what's next. I think this is the very, very first time that is we have to read the future and start preparing ourselves. And I repeat it again. We repeat ourselves, not repeating from doctors or consultant level, but we have to go down to the student level. That is, we have to prepare our student as they know the anatomy. They have to know what is the what is the artificial intelligence, the computer thinking, that is virtual realities, and all these things, because that is to prepare them how to work with the AI in the future. Ethics is a problem. And the people, maybe you know that is, I wrote 4 books about ethics, and this I have been involved with ethics in World Federation for more than 30 years. Ethics, even the history of ethics has changed. Ethics before, for all the history, we used to wait for an event, and then this event presented to the ethics committee, and the ethics committee come to decide this is right or this wrong. But now the game is different. That is, the ethicists have to step forward and to go forward and predict if you use the AI and artificial intelligence in that direction is good, and if you use it in that direction is not good. So I mean, ethical code has to be produced, and it is necessary to produce such ethical code. I know European society produced one. I think that Japanese, they trying with Far East to produce one. I'm not sure it is. United States starting to produce one, but still we don't have a global ethical code about use of artificial intelligence in medicine in general and in neurosurgery in particular. Maybe Dr. Nasser can take this task for the World Federation, or Dr. Kato with her super connection, because it is needed to have such a global ethical code for use of artificial intelligence in neurosurgery and medicine. Because what is coming, I believe, more complicated than we have now. We have to be one step forward. I am very glad, and I would like to thank everyone again. And I'll be very happy if we can go for a second and third meeting discussing the same issue. Thank you very much.
Thank you, Prof.
I don't know if I am chairman of the session. Should I close, or Dr. Chang is going to close it?
May I call upon Professor Yoko Kato? Maybe she would like to share some her views and comment about AI on the impact of neuronursing. Prof. Kato?
What? So before me, maybe Dr. Ahmad from Afghanistan. Dr. Ahmad?
Yes.
Fawad? No, sorry. Fawad, sorry. Dr. Fawad.
Assalamu alaikum. Kumbawa. Greeting. Thank you very much. Thank you very much. It's very nice to see Professor Kato, Professor Nasser, Professor Amar. It's very excellent presentations, and this is essential. Unfortunately, beside the basic neurosurgery in Afghanistan. Unfortunately, we haven't neuro nurses and also neuro anesthesia, neuro ICU, and we have difficulties. We like to draw your attention for this in Afghanistan for training and for make observation and supporting as well in Afghanistan as well. And thank you very much. It was very, very basic. You mentioned very basic steps, and we need a lot. But I also suppose that we must have like this WhatsApp or email or Facebook. We have a connection through AI for neurosurgery. Make a link to share our experience, and we learn from you, from your experience, from AI, neurosurgery, neuronurse, and it will be a good communication. I propose this one. Thank you very much.
Okay, thank you. Forward.
Thank you.
Great comment. Okay, thanks. So my comments already, the Ahmad said everything, so but no need to say anymore. I think in 5 or 10 years in the future, still we need a time, I think, in many meetings, so such as diagnosis or treatments by AI or robot. A little bit advancement in robotics in Japan now. But I think biotechnology and also the global health, we need such techniques in the future. So today we have great listener, very great lecture by super leading professor and nurses. Thank you so much.
Okay. If there's no further comments or question, I think it's time for us to say bye-bye. Thank you very much, both the two speakers, wonderful talks, and the session chairs, commentators, and as well as the participants. Thank you again, Prof. Kato.